We prep and drape the skin in the usual fashion. We've got the anterior neck exposed in the sterile technique. We're going to palpate out the thyroid cartilage with the cricoid cartilage below it. And then below that are the tracheal rings. This gentleman has a fairly low riding cricoid cartilage. He's already extended on a neck roll as far back as he can. He's got some kyphosis, so he's not fully extended as much as we would like. We have to work within the limitations. Local anesthesia is going to infiltrate it into the skin. He's already been sedated and paralyzed. Now, about 1 centimeter below the cricoid cartilage, we're making a 1 centimeter transverse incision through the skin. Then we bluntly dissect out down to the. Once we've done that, we insert the needle under bronchoscopic guidance, aiming to be between the second and third tracheal rings, roughly 1 centimeter below the cricoid cartilage. Okay, and you guys are happy. Now we're in the endotracheal tube with the bronchoscope. And we're going to withdraw the endotracheal tube while transilluminating and applying pressure on the anterior trachea.
I will pull back. State should be on back.
Keep coming. Keep coming. There we go. We can see the cricoid cartilage and the first, second, and third rings on the screen. Dr. Brindley, if you could rotate the other way. There we go. We have the tracheoesophageal membrane at 6 o'clock and the anterior trachea at 12 o'clock lined up. Now insert the needle, probably one space too high. Good. We've done that. We're being very careful not to puncture the tracheoesophageal membrane and cause a tracheoesophageal fistula. Now we insert the guide wire until the J-tip reaches the level of the carina or just into the main bronchi. We remove the needle over the guide wire and we use the first dilator. Now we use the blue rhino dilator with the introducer for it. We've already activated the tip of the blue rhino with some water or saline, and we advance the blue rhino until it reaches the marking for the skin to dilate the tract. Then we remove the blue rhino but leave the white sheath in, and we've preloaded a number 8 vortex tracheostomy tube onto the appropriate sized dilator to act as a conduit to get in. We see the tracheostomy tube cuff is well within the airway, just like we would like. Then we inflate the cuff, and as we're inflating the cuff, we stop ventilating up top, and we assess the tracheostomy tube position with the bronchoscope to ensure that it's in the middle of the airway, along in the middle of the airway. Yep. So we're in the airway, and now we can ventilate through the tracheostomy tube. We're electing not to suture the tracheostomy tube in place, but we will secure it by first cleaning the area with gauze, and then applying drain gauze, followed by Velcro tracheostomy ties, which we secure quite well. We found very little evidence or very little experience to substantiate the need to suture the trach flange into place. as long as it's an appropriately sized trach.